Hello, friends. Today's topic of discussion is hypertensive disorder in pregnancy. And the main aim we are going to look is the burden, how it is it's prevented and how it is predicted and how it has to be managed. Me, Dr. Sanjay Prasad Gupta, a gynecologist. Now, the hypertensive disorder in pregnancy complicates 5 to 10% of the overall pregnancies. And in our subcontinent, that is in Indian subcontinent, there are three major causes of maternal mortality. One is hemorrhage, next is sepsis, and third one is the most common complication leading to maternal death is hypertensive disorder in pregnancy. So it is a major cause of not only maternal mortality, but at the same time, perinatal morbidity. The clinical course of the hypertensive disorder is very variable, it very unpredictable as well, and it differs from one individual to the next. And at the same time, it is not possible when a woman will suddenly will deteriorate from a non-severe variety to a severe variety. So, where is the key challenge? How to prevent these major complications is the early prediction, timely prevention, and management. So, how to do that? Let us see in our further workup. Now, the main burden, if we look globally, it complicates 5 to 10% of the pregnancy. But in Indian subcontinent, it is more than 10%. So it accounts for 10 to 15% of maternal deaths, major cause of fetal growth restriction, and leading to preterm birth and small for gestational age babies. So how do you define hypertensive disorder in pregnancy? Number one is gestational hypertension. When the blood pressure, as we all know, is more than equal to 140/90 after 20 weeks, not associated with proteinuria or any end organ damage, we stamp it as gestational hypertension. But if it is associated with proteinuria or any other maternal organ dysfunction or uteroplacental dysfunction, then we stamp it as a case of preeclampsia. There is a term which is atypical preeclampsia. Here, the pressure may not be in the higher range, but there is proteinuria along with other associated organ damage. And if the preeclampsia start after 48 hours of the delivery or before 20 weeks of gestational age, so we all these groups or category, we call it atypical preeclampsia. Otherwise, usually the hypertensive disorders comes after 20 weeks only, and it is termed as gestational hypertension when not associated with proteinuria or any end organ damage, and preeclampsia when it is associated with end organ damage or proteinuria associated with hypertension which is more than equal to 140/90. Now, we are more worried of the severe variety of preeclampsia. So when we call it severe, when the blood pressure is more than equal to 160/110, it is associated with cerebral or visual symptoms such as headache, blurring of vision, scotoma, sometimes it may present as blindness, epigastric or right hypochondriac pain, nausea, vomiting, pulmonary edema, thrombocytopenia, elevated liver enzymes. Another two factors are also there, which some international bodies has removed from the severe variety, is oliguria and fetal growth restriction, which also we should consider that whether the preeclampsia is in the severe range or not. So ultimately, the hypertension, the disorder in pregnancy is a spectrum of disorder which starts with gestational hypertension, where only the pressure is high. Number two is preeclampsia. Here there is proteinuria or and any other end organ damage, which may be severe form or non-severe form. Then if it is associated with tonic-clonic convulsions, then we term it as eclampsia. It may convert into HELP syndrome also when it is associated with hemolysis, elevated liver enzyme, which is twice the normal range, and low platelet count. Next, if it is superimposed in chronic hypertension, and when we call it chronic hypertension, when the blood pressure is present preconceptionally or before 20 weeks of gestation. Now, next variety of classification is when it is diagnosed before 34 weeks, then we call it early onset. And when it is diagnosed beyond 34 weeks, then we call it late onset preeclampsia. Why early and late? Because early onset preeclampsia is more prone for maternal and fetal complications than late onset. Next is, if we, in a short, if we look for the pathophysiology of hypertensive disorder, so it is a two-stage model. In the stage 1, the problem occurs at the placental level. Here, there is abnormal trophoblastic invasion. Usually, the trophoblast invades up to the myometrium of the spiral artery. So, if the invasion is restricted in the decidua itself, then there is a defective spiral artery remodeling, and that is the main pathology which occurs at the placental level in the stage 1. Now, after this pathology, the stage 2 part, that is the maternal part, comes into the picture. So, because of the less invasion and improper spiral artery remodeling, there is ultimately release of cytokines and other oxidative stress factors that will lead to endothelial dysfunction, increase in the soluble FMS like tyrosine kinase 1, decrease in the placental growth factor, and that will ultimately lead to vasoconstriction and hypertension. So these are the two-stage model for the pathophysiology of the hypertensive disorder. So for now we know that hypertensive disorder of pregnancy is the but the burden is very high, and at the same time it complicates more than 10% of our pregnancy, and it leads to maternal and fetal morbidity along with mortality. So what is the need of the time? Need of the time is to predict as early as possible, and we start the preventive measures so that the mother and the child can be saved. So how to do the prediction? So International Society of Hypertensive Disorder in Pregnancy has come up with a gestosis scoring. So if a mother encounters you at the first antenatal visit, then you do the gestosis scoring, and if it is more than equal to 3, then you start on ecosprin as early as 12 weeks to 16 weeks of gestational age, and as late as up to 28 weeks also if the mother comes later. And it should be continued up to 36 to 37 weeks or before the onset of delivery, and it should be taken after dinner. So what is the gestosis scoring? So the state model has come up with 10 criteria. The mother having those criteria, we should start on ecosprin from 12 to 16 weeks. So what are those 10 criteria? One is age below 19. Next, age above 35. Number 3, if the mother is obese. 4, if she is having twin pregnancy. 5, if the pregnancy is conceived by ART, that is artificial reproductive technology, if the mother is having chronic kidney disease, if the mother is suffering from chronic hypertension, if the mother is suffering from diabetes mellitus, if the mother is suffering from any autoimmune diseases or SLE, or if the mother is giving history of hypertensive disorder in pregnancy or preeclampsia in the previous pregnancy. So all these categories should be started on ecosprin as early as 12 weeks to 16 weeks after dinner, and it will prevent the chances of hypertensive disorder in pregnancy up to 60% of the cases. So this is the state model of family and health and welfare department. Now the international guideline has come up with a gestational scoring, and they have given 1, 2, 3 scores, and if you add up, and if it comes more than equal to 3, then we have to start on ecosprin from 75 to 150 milligram as per the weight of the mother. So what are those? If we can look at the scoring, the factors, one is age older than 35 years, which is scored 1. Then age younger than 19 years, scored 1. If the mother is suffering from anemia, the score is 1. Obesity, BMI is more than 30 kg, 1. Primigravida, 1. Short duration of sperm exposure, 1. Women born as small for gestational age, 1. Family history of cardiovascular disease, 1. Polycystic ovarian syndrome, 1. Inter-pregnancy interval more than 7 years, 1. Conceived with IVF or ICSI, 1. Mean arterial pressure more than 85 millimeter of mercury, 1. Chronic vascular disease, that is dyslipidemia, 1. Excessive weight gain during pregnancy, 1. Now the score is given 2 in the following cases, that is maternal hypothyroidism 2, family history of preeclampsia 2, obesity more than 35 kg per meter square 2, multifetal gestation 2, hypertensive disorder in the previous pregnancy 2, now the following category should be scored as 3, that is pregestational diabetes mellitus, chronic hypertension, mental disorders, inherited or acquired thrombophilia, maternal chronic kidney disease, autoimmune disease, pregnancy associated with surrogacy or oocyte donation. So if the mother comes with the in the first antenatal visit an encounter to a physician, then we should score the as per the gestosis scoring chart, and if it is more than equal to 3, then we must start ecosprin to prevent hypertensive disorder in pregnancy later on and its consequences. So this is the gestosis scoring concept in short by the International Society. Now there is Fetomedicine Foundation and ACOG also recommending for a combined test which can be considered when the options are available. What are those? Maternal factors, mean arterial pressure, uterine artery pulsatility index, platelet growth factor, and pregnancy associated plasma protein A, that is PAPA. So if we consider all these factors, then it can detect the preeclampsia as per up to 90%. So if we do according to this, and if we found it is in the high risk range, then we can start with ecosprin between 12 to 16 to 18 weeks. Now, so if the options are available, otherwise we can go with the gestosis scoring as provided by the international guidelines in each mother, and this factor we can see at each encounter whenever we see the patient in antenatal care. Now next is the if you look for the biomarkers which are available to us, if at all if the setup provides the facility to go for the biomarker test, that is at the 11 to 13 weeks, we are going where the facilities are available for the aneuploidy screening. That is the triple marker, NT scan, beta HCG, and PAPA. Here also we can add placental growth factor. So, and if added with the Doppler study of the uterine artery, then we can predict the hypertensive disorder in pregnancy. But if placental growth factor is not possible to do, then PAPA will also help for the scoring and starting on ecosprin if needed. And if in the later range, that is in the 19 to 24 weeks, if you want to predict, then the two biomarkers are more important, is placental growth factor and serum FMS like tyrosine kinase 1, that is soluble FMS like tyrosine kinase 1. Now next is when the, so we with this gestosis scoring, or if the availability of biomarker is there, we can predict the hypertensive disorder, and we can start ecosprin as a preventive measure. This is number one. Now number two, if the mother is already suffering from hypertensive disorder but away from term, so in that case we have to follow up so that it, as far as we can go to make the baby, make the fetus mature, and our main aim is to go as near to term as possible. So in those cases we should do the follow-up examination, and at the same time there is a recommendation of doing a ratio of soluble FMS like tyrosine kinase 1 and placental growth factor. If it is less than 38 to 40, then next 1 to 2 weeks the hypertensive disorder is not going to be severe, and we can wait at least for next 1 to 2 weeks. But if it is more than 85 or more than 110, when we cannot wait, because mother will turn up into a severe form, and so we should look for the consideration for the delivery, and that is the definitive treatment of hypertensive disorder in the pregnancy. Now next is, when these types of biomarker studies are not available, then what to do? So their Pierce risk scoring, that is pre-eclampsia integrated estimate of risk study group, has come up with the variables, and from there we can predict whether we should wait or whether we should terminate the pregnancy. And there are some mini Pierce variables, that is parity, gestational age, systolic blood pressure, proteinuria, symptoms, which is headache, visual disturbance, chest pain, dyspnea, vaginal bleeding, abdominal pain. And if we have to put in the Pierce scoring, the data has to be put in the Pierce scoring formula, and if it comes less than 1%, then no need to take action, because chances of severe form is very low. But if it comes more than 10%, then we should consider, or more than 5 to 10%, then we should consider for the delivery to prevent the complications. So the Pierce helps to decide who will deteriorate in the next 48 hours, and accordingly we can take the decision. So till now we can guess who by the gestosis scoring, or if available by the biomarker scoring, who are going to be hypertensive in future, if at all. So as a preventive measure, we can use ecosprin 75 to 150 milligram to be started between 12 to 16 weeks, as late as 28 weeks if mother comes later, and it has to go up to 36 to 37 weeks or before onset of labor. And at the same time, calcium supplementation is also equally needed in the range of 1 to 1.5 grams per day. It also helps somehow by reducing the level of the blood pressure, and in a way helps in reducing the hypertensive disorder in the pregnancy. So how to manage a hypertensive when it develops hypertensive disorder? So we have to monitor the BP, we have to look for the urine, protein in the urine, we have to go for the complete blood picture, liver function test, renal function tests, fetal growth, and Doppler monitoring. And this has to be done as per the severity of the disease. If it is mild disease, we have to go for the expectant management till 37 weeks, and after that we should look for the delivery. And if it is in the severe variety, then we have to stabilize the mother, we have to control the BP, we have to take preventive actions so that it won't develop into seizure, and then we need to plan the delivery as per the gestational age and conditions of the mother. What are the antihypertensive we usually use is labetalol, nifedipine, and the target is in the antenatal period should be less than 140 and 90. Seizure prophylaxis, the gold standard is magnesium sulfate, and timing of delivery, if it is more than equal to 37 weeks, we should not wait, we need to deliver. If it is in the severe variety of preeclampsia and more than equal to 34 weeks, we need to deliver. And if it is less than 34 weeks, then we have to give steroids, stabilize, and as per the condition of the mother and the fetus and all the factors we should take into account, and we should consider for the delivery. So next is in a short we can what are the complications can develop a hypertensive. It can turn into eclampsia. It may develop into HELP syndrome, that is hemolysis, elevated liver enzymes and low platelet count. It can go into cerebral stroke, renal failure, and FGR, as we all know. So take home message is hypertensive disorder is a major killer, but it can be predicted and prevented if we do the proper history, counseling, and preventive measures. Early screening, as per the Feto-Maternal Foundation, is the best way to prevent the hypertension, and aspirin reduces the risk significantly. Pious scoring helps short-term decision making, and timely delivery saves the life of both, that is the mother and the baby which is going to be born. Thanks, and if you want similar type of video in future, do subscribe my channel. Jai Hind.